Hey everybody. Uh, just doing a quick sound check and then also just making sure our folks here for the state-based single payer talk. If you want to give me a thumbs up, excellent, excellent. Thank you. We're just getting some other folks in here, so it's 2:59. We'll be starting a few minutes after the hour. Very excited to see you all. Thank you so much for joining. And there's my wonderful colleague, Gloria Mattera, in here too. So thank you. Gloria, and I'm going to make you a co-host as well.
We could actually, I think, turn off the waiting room so people just come in.
Yep, that's what I'm going to do as well too. Oh, you have co-host privileges already, Gloria.
Yeah.
Yep. Okay.
I have a question. I'm legally blind. And
Go ahead, Adam. What?
oh,
Sure.
I had a question. I'm legally blind, and it's hard for me to like raise my hand on here and things like that, and reading things like the chat. And so I know that when I'm on a lot of other Zoom calls on other platforms, I've had the host has like left my camera and my mic unmuted so that because it's always hard for me to find the buttons to hit, if you know what I'm saying. And
Sure.
what I do is I can just mute my mic from my headset itself. You know what I'm saying? Instead of hitting the buttons that's located somewhere on the computer. And I didn't know if you guys could leave those open just so that if I have to raise my hand, if you know what I'm saying.
That's fine. And I'm hoping that if people don't have a lot of noise going on in the background, we weren't planning on muting everybody unless there was some
Oh, okay.
issues. Um, Hopefully everybody will be listening, and then there'll be opportunities for people to talk. But it also sounds like if you have a question at the end, you will maybe just, since you can't raise your virtual hand so easily, you can either wave or you can just say stack.
Stack.
Yeah,
Yeah,
sure.
that's what that's why I was just like, if you know what I'm saying, that's why I was just curious. So because I
Sure.
know some people when they do a Zoom meeting, they like shut everything down and they're like, okay, if you want to talk, then send us a message in the chat. It's like that doesn't help me.
Yeah. Sometimes we
Can you
have to do
see?
that, but we don't want to do that.
Yeah. Can you see me at all? Or
Yeah.
okay, I just want to make sure you can see me. I can't see myself in here, so
You
oh
are
there.
set up perfectly for us to all see you. So,
Okay. All righty. Oh, all right.
okay. So welcome everyone. Danny, I'm looking for you.
Hi everybody. Just letting a few more folks in, but I think that's great. It's 3:02. We're going to just wait a couple more minutes. Gloria, if you can, I was trying to turn off the waiting room, but I don't see that. If you can just keep letting folks in, and I'm gonna
Sure.
share a quick poll in just a moment.
Yep. Let's see. Okay. Uh, I have disabled the waiting room. It's in host tools.
Great. Thank you, Gloria.
And so when we decide to start officially, one of us will hit record. Who will do that? You or me?
It actually came in recording already, so I'm just gonna double check. That's on my list of things to make sure. Yeah,
Oh yeah, we
see.
should have paused it. We don't need all this.
Okay. And I'm gonna share my slides here. All right, Gloria, thumbs up if you can see that. Okay, great. So, welcome everyone. My name is Danny Lugassy, he, him. I'm one of your co-presenters for the States Can't Wait, state-based single-payer movement, how Greens can advocate for universal healthcare coverage now. Um, I'm going to turn it to my colleague to introduce themselves and talk a little bit more about what they do, how they're involved in healthcare advocacy, and obviously how they're involved with the Green Party.
Hey,
Gloria?
everyone. Yeah, great to have you here. Great to be working with Danny again. I'm Gloria Mattera, currently co-chair of the Green Party of New York. I'm also a longtime board member of Physicians for National Health Program, the Metro chapter, which is also colleague of Danny's in that on that organization. I'm based in Brooklyn. I've been working for over 35 years in the public hospital system, mostly running a child life department, basically working with children and families, primarily of immigrant families, often undocumented. It was really the eye-opening experience to start working in the public hospital system that really introduced me to the need for a national health program. Uh, Interesting about that is I soon realized that the Democrats were never going to be able to do that. So it led me to the path of independent left political politics. And I have been in the Green Party since 2000.
Thank you so much, Gloria. So, just an absolute pleasure to be presenting again with Gloria, who's both a friend, a mentor, inspiration. I'm an emergency medicine physician. I've been practicing for over 20 years in emergency departments in New York City, Baltimore, some of the busiest places in the country. I am also a board member of Physicians for a National Health Program. Actually, in medical school, started the first medical school chapter 25 years ago. So I have been thinking and working in and around single payer advocacy for 25 years. Um, During the Occupy Wall Street movement, I was very dismayed by what I was seeing around healthcare advocacy, both with the passage of the Affordable Care Act as a longtime single payer advocate, and really got connected to the Green Party of New York and the Green Party of Brooklyn, and thanks to Gloria's mentorship and friendship. Both of us, again, are on the board of Physicians for a National Health Program, but we both have no financial disclosures. We're not paid. That's a voluntary position that we do. So what are we going to be talking about today? I'm going to share a story to start out with. If you've ever heard me speak on single payer, Medicare for All, and state based, you know that that's what I always like to start with. Gloria is going to share one later. So imagine I'm working in a busy emergency department. It's a major trauma center in New York City, and a 25-year-old man is rushed into the emergency department. EMS states that he has a completely mangled lower extremity. The bones are sticking out of the middle of his lower leg. I spared you a bloody image, so this is what the x-ray would have looked like. Um, he was just walking down the street on a busy Manhattan afternoon and a truck sideswiped him. The truck, whether it was intentional or not, had no idea that they even hit him and his leg coming off the curb and just kept going. So he's rushed into our trauma center and he's screaming and he's yelling. And when we think about a patient who's in trauma, we're worried, is he confused from some kind of head injury? Does he have bleeding somewhere else? Because the report from EMS is it's an isolated lower leg injury. So if you've ever seen any emergency department TV show, or unfortunately, if you've been around, hopefully not as a patient, there's a swarm of folks who surround you. It was probably about 10 or 12 people sticking him to get an IV, taking off his clothing, trying to find life-threatening injuries. We certainly see how bad his leg is. So he starts screaming and yelling. He becomes really uncomfortable and says that he needs everyone to stop what they're doing and pushing people away. He does not want his blood drawn. He does not want an IV. And I walk to the head of the bed and try to calmly talk to him and say, "Hey, look, I'm Dr. Lugassy. We're really worried about your leg. Can we please help you?" And he says to me, looks at me, and says, "Look, doc, can you please do the bare minimum possible? I just switched my job. I haven't been there for 3 months. I don't have health insurance. I don't think I can afford this." And those are the moments which I often say is a stethoscope drop moment. So, you know, the mic drop, you just leave after the mic. This is one where no matter what I'm going to say to this person in that moment, I can't guarantee that I'm going to resolve what this medical bill is going to cost him. But one thing that sickens me to my gut is instead of him asking me, Doc, do everything possible, save my life, save my leg, make sure that I can walk again, run, cycle, whatever it is, he's more concerned about the bill. And it's, you know, it's just a moment where all of my training, all of my expertise, all of the folks around me, we don't have a great answer for him. We can tell him we're going to do the best job possible, and we can tell him social work and other folks are going to come help him with his bills. But we ultimately, no matter what is going on with his insurance status, his income status, we don't know what the ultimate cost is going to be. Um, and so, you know, I don't usually tell you the resolution of these stories because it's enough to just think about that. But I will tell you that I followed him on those next few weeks and he had to have a leg amputation. That's how bad his leg was mangled. So again, instead of being concerned about his life or limb, he was more concerned about debt and cost. So today we're going to talk about state-based single payer. We're going to review a very brief history of this movement. It's actually much longer than even I knew when I first started getting into it. It's been around for quite some time. We're going to use New York, California, and Vermont as mini case studies of what's happened and what is happening today in those states. We're going to highlight some of your concerns and debunk some of the common myths about state-based single payer. And towards the end, Gloria and I are going to share strategies and tools on how you can advocate tomorrow and lobby tomorrow your elected state representatives for single payer in your own state. All right, so what's the problem with the US healthcare system? Right. I will give you a plug later that Gloria and I last year talked about Medicare for All and the huge problem of US healthcare delivery, but we really just need to ground ourselves in that reality before we move into state-based single payer. So how much are we spending on healthcare? You know, most of you are probably very well aware of the premium, deductible, copay, coinsurance, right? Premium's your gym membership, what you pay every month. Deductible is how much you have to pay out of pocket annually before insurance starts to cover that. Copay is that copay you pay each time you go to a specialist, primary care, etc. And then coinsurance is ultimately the percentage that your plan will pay after all you cough up all of this funds. So when I got into single payer advocacy 25 years ago, we were screaming about how we spend over $1 trillion annually in the United States on healthcare. Well, that just keeps going up and up and up. The latest estimates are almost $5 trillion a year spent on healthcare. This is a very self-explanatory graph. In the beginning of my single payer advocacy around 2000, 2001, a family of four average employer employee contribution to a premium, that's just the premium for the year, was about $7,000 and workers were paying about $1,000. Well, the average premium now is almost $25,000 for a family of four annually, and workers are paying 5, 6 times more than what they were paying just a few years ago. Deductibles are just insane. I remember seeing deductibles as low as $25, $100, and then now we have category of deductibles over $3,000, and almost a third of folks have reported a deductible over $2,000. So again, after premiums, all of that, it's a first $2,000 before you're getting your coverage paid for from your health insurance plan. You know this, you've seen this graph, right? There's one thing we do better than any other nation listed here. We always talk about American exceptionalism. Well, we spend almost 18% of our GDP on healthcare. It's nearly triple, quadruple, sometimes 5 times greater many nations that have similar economic and structures, societal structures to us. You know, we have the most expensive healthcare in the world. How does it stack up when you look instead of GDP? We're spending over $12,000 per person on healthcare. Again, 2, 4, 5 times other nations. You look at Canada, UK, they're spending less than half what we are per person. What do we get for all this cost? Well, Gloria and I have been in the single payer fight for a long time, so we've been following the uninsured. And with the passage of the Affordable Care Act, the uninsured number did drop from the 40s of millions to the 20s of millions. And then, oh, by the way, something happened in 2020 where they conveniently leave out that year. And what happened, you all know, was we were in the midst of a devastating global pandemic. And what we really don't ever know is how many folks actually became uninsured at some point during that year. We know since your job is often tied to your ability to pay or have health insurance, and with all the folks who lost their employment, it was in the high 50s or 60s millions at least. What we know, still around 27 million folks with no insurance at all, about 8% of our population. What else do we get for all this money we pump in? Well, you know, we rank well behind other nations on healthcare performance, on life expectancy. We're really far behind. Death. Not being insured leads to death. At least 45,000 people die each year. Now, this is an older Harvard study, which many folks quote. Many believe it's almost 1.5 or 2 times what that is now. So it's not only that it's gotten worse, we're spending more and we're still having many folks die from a lack of coverage. To me, I thought this was going to be a watershed moment. We're living through a global pandemic. I'm in the midst of the epicenter in New York City in the emergency department of taking care of COVID patients. And I thought, surely we will all smarten up as a society and realize we cannot go another day without single payer throughout the nation. About a year plus 2 years into the pandemic, the Yale School of Public Health published a damning report of our healthcare system. Of the first 1 million folks who died from COVID, over a third would have been prevented if we had a Medicare for All system. And in that year and a half plus, we would have saved over $100 billion. So I don't know what else I can show you to tell you that we need a big change. What else do we get out of our system? Well, one thing we know, and we can do hours of a discussion on this, is that we have widespread healthcare access disparities. Just looking at race and our immigrant community, you can see all of the ills of our society often play out in healthcare. This was shared with me a few years ago by a mentor. Rudolf Virchow was someone who was a famous physician, worked on cells and microscopes. He said that medicine is a social science and politics is nothing but medicine on a large scale. So when we see racism in our society, unfortunately for me at my job, I have to look no further than where I work to see that segregation in care and in the system. Maybe you've heard Black maternal mortality across the nation when compared to white women is 3 times greater. And even inside New York City, where we have a robust public health care system and we're supposed to be more in tuned to some of these issues of segregation and racial discrimination in our healthcare system, we just a few years ago were almost 10 to 12 times greater in Black maternal mortality. The numbers improved, but it's still 5 to 8 times greater. When we look at the uninsured folks across the nation, our people of color make up a greater majority of that uninsured population. I often say when you work in the academic and public healthcare system in New York City, you only need to use your eyes and look at what we see in the emergency departments at the different institutions to see how racially segregated we are. And this study from Black prove that. Essentially what they looked at is Boston and New York City. They looked at academic and public health hospitals. And the bottom line is that 50% of Black patients would have to switch from the public hospital system to the private or academic medical center system to equalize the rates of the patient population. Here's a chart Again, this is in an area that Gloria and I work in New York City. You see, you have academic medical centers and public hospital systems. Bellevue, NYU are academic and public hospital systems that are just a couple blocks away from each other, literally 2 or 3 Manhattan blocks. And when you look at the folks that are being taken care of who have Medicaid insurance, who are uninsured, it dwarfs those that go to the academic medical center just blocks away. As a son of 2 immigrants, we often hear a tremendous amount of misinformation and attacks on the immigrant community in relation to healthcare access and utilization. But let's lay some facts out. First of all, 17% of the US workforce in healthcare are immigrants. So we don't have immigrants, we're not going to have a healthcare functioning system. We often hear a slander that immigrants are using up all this health care and that's why it's so expensive, and they're really all the uninsured. False. Only 15% of the uninsured were ineligible due to immigration status. It's about 4 million people of the 27 million who are uninsured. Here's a big dirty secret that I want you to pass around. Immigrants' wages are taxed. Many of you probably know that. And in fact, if we didn't have those wages to tax and collect for Medicare, our system that takes care of folks for 65 and older, that system and that pot of money would collapse because immigrants contribute way more, in an excess over a few years, 75 billion more than they get out for the cost of healthcare. In fact, US born folks are taking out almost 100 billion more than they contribute. You've probably heard this before, but it's important when we talk about healthcare insurance and access, we're not necessarily talking about actual care. We're even just talking about the simplicity of getting in the door and not having financial ruin for care. Healthcare in the United States is a commodity. That's what Occupy Wall Street was about, and that's what much of our movement is about. To remove the for-profit industry that is basically selling and trading our lives for profit. So in summary, we have less healthcare system that we spend more, get less, have poor outcomes, wide healthcare disparities, and oh, by the way, we have something else which could not be more embarrassing and shameful. We have bankruptcy due to medical bills. And I think this is probably the most critical infographic that I've ever seen. In the United States, almost 700,000 folks each year go bankrupt due to medical bills. It's literally zero in these other nations like France, Japan, Germany, Canada.
Danny,
And in
sometimes
fact,
your, sorry, Danny, sometimes your
personal
audio
bankruptcies
is,
are
sometimes your audio is going out. I don't know why that might be. I don't know if anybody else hears that.
alert about my internet. We're about to enter some massive hurricane-like storm in the New York City area. So thank you, Gloria. Stop me again if that's breaking up. Is this better right now? Okay. I think one thing again we do not talk enough about, the folks who go into medical bankruptcy, 75% of had insurance when they go medically bankrupt. 60% had private insurance. So don't tell me you love your private insurance because it's not saving you from financial ruin. Now, to kind of end this section, I know I'm asked about the big blank bill, whatever you want to call it. We know it's not beautiful at all. It's got lots of different pieces, and one piece that is going to affect is our healthcare system. There's going to be less regulation. There are Medicaid cuts. There's going to be increases in premiums, and we're going to see insurers basically mess with people's premiums due to their pre-existing conditions. Many things we thought we got rid of. But in summary, one thing that you've been hearing about is over several years, this big, beautiful bill will have an additional 16 million people who will be uninsured. When you look at states, just to give you an example, Florida, Texas, quote, red states, it's 2 million folks in those states that are going to be 2 million more that are going to be uninsured. In New York and California, that's going to be a 4% increase. So just really half those other states, but significant numbers still. So what is state single payer? Well, you may have seen this slide. What we have right now is a very complicated, convoluted system. About half of us get our health care through our job, through a private insurance plan, where we pay a part of the premium and our employer pays another part. Another quarter of the nation gets their healthcare through a government-sponsored program like Medicaid or Medicare. And again, if you want to learn more about that, we're going to share links in the end to our talk from last year. And we have a taxation of the system. Some of that goes to our premiums and deductibles. Medicare, there's a lot of administrative waste. The way doctors and hospitals get reimbursed, sometimes it's from the private insurance company, sometimes it's directly from us in co-payments, sometimes it's from the government for uncompensated care. It's very, very convoluted. It's very wasteful. So we often talk about single payer, which is one single pot of money and one single, you're a business, you pay a tax into the government that collects a pot of money, or you yourself are taxed and that goes into, again, a pot of money. We then all are under a public health insurance plan. Often we say Medicare for All, and then all of the reimbursements for doctors' fees, hospital fees are paid through one pot of money. The four key elements of single payer that we're going to look at the state level, again, that there is one payer. This is how we save the most money. 2, we have a budget. The hospitals, nursing homes, other facilities get an annual budget. 3, uniform fees. You can't walk into one hospital and it costs $10,000 for a normal natural birth, and then $1,000 for at a different hospital. We have such variations. Price control. One thing that single payer does is finally control the amount that drug companies can charge us and device companies as well. So you often hear us say Medicare for All. Why is that? Medicare collects a tax pot of money and then pays doctors, hospitals for that care. Medicare operates at about a 98%, about a 1 to 2% overhead, which means 98% of the dollars collected are used to actually compensate care. Insurance anywhere 20 to 12% as for all is cradle to grave. So for the moment you're born, you will then have this coverage. It's for everybody, regardless of job, income, and immigration status. And guess what? It's going to cover all necessary health care, right? All of us have medical insurance, but we also have to carry dental, vision, hearing, etc. We often joke, we have to remind folks in the single payer movement that your ears and your teeth and your eyes are still part of your body. You often hear us say improved and expanded because Medicare is for 65 and older and other stipulations. So we want everybody in and nobody out. You'll often hear that chant. And we want it improved to cover all of those items that I just mentioned. Medicare for All is still delivered privately by the hospitals just the way they are today, but publicly funded system. So what's the difference between Medicare for All and a state single payer plan? Not much. Here's an orange and a tangerine. If you understand Medicare for All, it is simply those four key concepts at a state level. Obviously, it is going to be run and administered in a different manner, but many healthcare programs are delivered and administered by the states. How is that paid for? Well, anything that the state gets in taxation from within their state or from federal support like Medicare and Medicaid, or even within the ACA Affordable Care Act exchanges, can be rolled into one pot of money that a state can use to create a comprehensive plan that would cover everyone. Right now, in the state single payer legislation movement, we have seen many different states. In fact, over 20 states over the last 10 or 15 years have introduced 59 different unique single payer bills. I will tell you some of them are, quote, more single payer than others. Some are single payer light. Some are true single payer, like in New York and California and other states. So you kind of have to look at each state and each situation individually. But this is a movement that has been around for many years, but often doesn't get a lot of attention, which is why we want to talk to you about it today. So we're just going to briefly highlight what happens in New York. We have a state single payer bill that Gloria and I have worked on for many years, and I want to just unpack some of the features on how it can work in your state or if you're living in New York so that you can know more about it. So when you look at New York, we have about 5% of our population who's completely uninsured, over 1 million people. About 3% of those folks are white. And what we see is that the highest uninsurance rates, guess what, are in the brackets of income between $25,000 and $49,000. There's been multiple studies, time and time again, showing that when you poll New Yorkers across the state, 2/3 of them experience some affordability burden in the last year. And almost 80% of them say they are worried about healthcare costs in the future. When you look at who says they're worrying about cost, you can up income level 50 to 75 to 100K a year, more than 100K. Everybody is saying 75% or greater, up to 90%, worried about affording care. And that's regardless of whether you have insurance to a family member, on your own, you're living on Medicaid or Medicare. We're all worried about the cost. These are embarrassing statistics that, again, I can't believe I operate and work in a healthcare system that will put liens on people's homes and garnish their wages if they can't pay for a hospital bill. Over a 2-year period of time, this report showed there were 5,000 liens in that state alone, with 56 hospitals involved. Albany is our state capital. And if you look at the city of Albany itself, more than 10% have medical debt. And when you look at those who carrying the greatest burden of medical debt, a quarter of them are people of color. And the 5 nonprofit hospitals over a 6-year period of time in Albany sued almost 3,000 Albany residents. So we have something called the New York Health Act. It's been around for about 30 years, and it's had a reinvigoration in the last 10, 12 years. It is a state single payer bill that would cover every living resident, and a new stipulation a few years ago, anybody working in New York State. So we have a lot of folks who might live in New Jersey, Connecticut, but if they're working in New York State, they're taxed for their wages in New York State, they are covered by the New York Health Act. It's a comprehensive benefit of all the things I mentioned: vision, dental, hearing, full health care coverage, primary care, etc. No financial barriers, no deductibles, no copays. How do we do this? Well, we get the private insurance industry out of the way, and we save on all of that wasted money. And just a few years ago, we were seeing about $45 billion in multiple analyses of the bill, including some centrist think tanks that show about 90 to 95% of New Yorkers are going to pay the same or less for their health care. That net savings is actually about $20 billion. How do we do that? Reducing administrative costs, reducing the administrative costs in the hospitals, controlling drug prices, and with that saving, we can still cover everybody, improve fees for all different kinds of service, and actually incorporate long-term care. How do we pay for this? Well, this is a quick graph. The status quo is the blue line. And what you see, the more income you make above the federal poverty limit, the actual lower amount healthcare costs for your premium you're paying annually. What this does is that reverses that. The more you make, the more you pay in. It's a progressive taxation instead of regressive. And here's just a couple examples. So if your annual income is about $100,000 a year, the effective tax rate is about 12,000. So again, if you have that employer sponsored insurance, your employer is going to pay 80% at minimum. They can pay more if they choose, which is about $10,000 a year, and you'll pay about 2,400. And so what you're seeing here is that again, the premium is going to cover everything. You're going to be fully covered. When we talk about the top 5% earners potentially paying more into the system, we're talking about folks who are making $500,000 or more in a medium household income for the state around $75,000. A brief history of the New York Health Act. Just about 10, 12 years ago, it was reintroduced and we started lobbying, and people said, "Oh, it's really cute that you're here with your white coats. You've got about 20 co-sponsors in the assembly. You're never going to pass the assembly." We got to the point where we had a majority co-sponsorship, over 80, 90 folks. Then they said, "You're never going to get it passed. Speaker Sheldon Silver is never going to bring it to a vote." He was indicted for a healthcare scandal and booted, and the next speaker brought it to a vote. We passed the assembly 4 years in a row. And they told us, okay, that's really nice, but you've only got one or two co-sponsors in the Senate. From 2021 to 2024, we've had a majority in the Senate who are co-sponsors. Right now, we stand with a Senate majority, and we're just a few behind in the assembly, which just changed over in the last 2024 election. And we're pretty confident we're going to easily in the next few months get back up to over 76. So with that, I'm going to pause here and turn it to Gloria. She's going to take us through a few highlights of what's happened in California over the last few years in state single payer. And Gloria,
Thanks.
I can do next slide when you're ready. Yeah.
Thanks, Danny. Just want to say, I know people put a couple questions in the chat. We will get to them. I've made a note in case they go too fast. So, yeah, starting with California, because they have a long history and really at some point had the most success. Next slide. Next slide. So currently it's called Assembly Bill 2200, right? So now this is the history. They've really been working on single payer bills, introducing it in the early 90s. Just in 1992, it's interesting that when Jerry Brown was running for president, in the debate, he said, "I believe the only healthcare system that makes any sense is a single payer system, similar to what's been adopted in Canada," which is what we say. When we fast forward later to when he became governor, he was one of the politicians who were most instrumental in keeping that single payer bill coming, for any possible vote. But in California, because they have ballot initiatives, Proposition 186, some states have that, some don't. 1994, it did go to a ballot vote, and it failed. And then, over the 30 years, very similar to New York, there have been various iterations of it. What's interesting is whether this is just how bureaucratic and the slow wheels of government work, or if it's stalling tactics, but there tends to be legislation first before we can look at the, having a single payer system. Let's establish a blue ribbon panel. And so we have legislation for that. Who's going to be on the panel? Like everything is slow steps towards that. I haven't quite figured out if that's just a stalling tactic or this kind of the way government works slowly. Next slide. So you may recognize this person either from his terms as governor or in the movies. But in 2006, California legislature actually did pass the first state single payer bill, universal health care for the first time in the United States. And then it was vetoed once in 2006 by Schwarzenegger, and he called it socialized medicine. That was the reason at the time. It passed again in 2008. At that time, he vetoed it, but he did not use that terminology. He just said it was going to cost too much. Next slide. A little bit more of what about kind of the trajectory of single payer in California is that once the Affordable Care Act passed in 2010, when Obama was president, it became a possible split in the coalition that was working on this quite seriously for a good decade. Some people, some organizations felt, and Democratic elected officials felt, well, let's see how we can work with, tweak, or do something with the ACA. Let's sit down and be at the table for this. Other single payer advocates continue to want to push for what a real state single payer or universal healthcare would be, actually. And then when Trump was elected and he was threatening get rid of the ACA to dismantle it, more interest in state single payer happened. Initially, there was a lot of focus on, can we do this nationally? It flat back to, can some states get this done? Since California was so successful to keep that up. Then they also passed in 2017 in the Senate a version of it, but actually the speaker, the Democrat Anthony Rendon, pretty much shelved the bill. And really, if you look at that reason why, it was he and Jerry Brown looking at how that was going to impact pharmaceutical donations, where most of them had been getting payouts, campaign contributions from the pharmaceutical companies. So it was a combination of worrying about their donors. I think we know a lot about that. And figuring out if this is really quote unquote feasible. Next slide. And so the latest for CalCare, last year it failed again this time in committee in the spring of 2004. One of the reasons why they said that was because it was supposedly going to cost $392 billion. There was $45 billion deficit in the state of California, so they felt that they had to back off the bill. And this quote is from, at that time, the president of the California Nurses Association, who was really a lead sponsor of single payer bill in California for a long time. In tough economic times, coupled with the erosion of traditional social safety net programs, a single payer healthcare program is needed more than ever. And that's certainly what we believe. Next slide. And so what are your concerns or criticisms of state single payer, right? And you may not have any. A lot of us have been working at that for a long time, but people are going to ask you and they're going to express their concerns. Next slide. So what are we going to say when they ask those questions? Can we do that without federal approval? Well, in some, because some states are going to say, well, can we actually do this? Can we afford it? In some states, yes, in terms of the New York Health Act, obviously you need federal waivers, which is a possible option for implementing state single payer. But the way the New York bill is written is that it can actually account for paying for this if they don't get the waivers. There are some states that are not going to have the same level of revenue generation. And Danny, I don't know if you have anything particular to say about that. We know like Ohio has just recently introduced a bill. Is that going to be a bigger leap for them to be able to have the kind of tax revenue to be able to fund it without the waivers? But getting a waiver now, my understanding is that recently passed to make it easier to happen on the federal level. Next slide. So what about unions? They don't like single payer because what about their welfare funds? And, they're going to be against that. They remember people back in the early days of fighting for single payer on a national level, we would hear about the Cadillac plans, which of course came out of the auto industry, where they did have what you would call Cadillac plans. Even my dad, who was a truck driver, he had what you would consider a Cadillac plan because it was amazing coverage for him and his family. But that has been eroding over the years, and we know even the percentage of unionized workers have been dropping. And yes, there are some unions that will say that single payer is not something they want to support. But at this point, majority of them are supported. And they're not going to lose the good coverage they have now. It means everybody's getting that good coverage. And I think that's the point we have to keep saying when it's everybody in and nobody out. This coverage is going to be the same, whether you're making $250,000, whether you're not employed at the moment, whether you're making $50,000 a year. And because one of the other reasons it's good for unions and those of us who have been in unions or working with unions when they're out on strike, when they're being pressured to sign a contract that's not good for them, it is often a choice. Well, you can get the cost of living raises, or you can continue with your healthcare plan. If we give you those raises, we're going to have to charge you more as the employee for your healthcare plan. And that is a typical bargaining, dilemma that when unions go to the table with management that they have to contend with. Next slide. And so people have talked about the public option in the past. Do we think this is a good thing to do? Just cover the uninsured people because of course they need something. Or give an option of doing that, and it's still going to be fragmented with different payers. So we want, and it's not really going to save anything. So we're kind of getting the worst of both worlds there, and it's just going to make private insurance feel that they don't have to insure those people who are the sickest. Remember, most of us would be in a system, a more single payer system where we're healthy, we're getting preventative care, right? But and that should basically, if we want to think about a social safety net and how as Greens we feel about society, then that means the sickest people, which is not going to be the majority of people, are going to be able to get the care they need because we're all in that paying into it what our income level requires us to do. Next. And then we do know, and some of you know, I have posted on the national list talking about the different movements saying, well, some universal single payer movements don't want to talk about state sponsored single payer. We have to go for the national. Does it detract from having Medicare for all? But, we can be that experiment. And if California and New York both have state single payer, that is a huge amount of people in this country that would show that this is possible and that this can really happen. Next slide. And to sum up, how did Canada get their single payer insurance system, their national health insurance program, not to be confused with what they have in some European countries, which is nationalized health care. It really happened in one province, Saskatchewan. And then once that was successful there, that's the momentum. That's the momentum we want to be able to build for it to continue to happen everywhere. And I will hand it back over to Danny.
Thank you, Gloria. And
Your audio is still a little
Gloria
choppy.
is saying, so if we're looking at Saskatchewan as a state, oh, can you hear me?
Yep, now it's good.
Gloria?
Yep,
It's okay. Yeah, you broke up
In a-
just at the end there a little bit.
I think
So,
that's happening to both of
okay.
us.
So, and we're monitoring the chat, and someone said, it would be great if one state did this and hopefully it would
Mhm.
domino. And that is exactly what we saw happen in Canada. And there have been other state social justice movements, such as same-sex marriage. States by state passed laws about same-sex marriage, and then it was legal across the nation. So we're hoping to create that. But Gloria, what about all the costs? Single payer in a state, maybe about to pass on a governor's desk, they talk about the cost. So just looking at New York State, remember, we're all drowning in medical debt as a nation as well, and on a state level. And when we look at the savings from a single payer bill, we're going to save about $60 billion because of getting rid of that administrative waste, marketing, profit, etc. It's going to cost 40 billion. So there is a net savings. And the lead co-sponsor often talks about how this would be the biggest increase in what we call take home pay for all New Yorkers in generations. right? Gloria mentioned the union fights over, do you want a better salary or do you want your healthcare benefits? You want to pay more of your premium or we pay more of it? But Danny, seriously about the cost, that's what people keep telling me. Okay, so I'm going to tell you two other things. I'll tell you three things. Number one, this graph here shows you private insurers, for example, showing their profits in one quarter, quarter two of 2020, right in the middle of the height of the global pandemic, as I was taking care of people who were dying left and right on my watch. They were making double what they made in quarter two of 2019, over 6 billion in profits. Okay. So don't tell me about costs. But again, people are asking me, but Danny, I heard single payer at the state level is going to cost billions of dollars and there's a state deficit. Well, guess what? There is no study that has ever showed that implementing a single payer plan will cost more than what we currently have. What we need to remember is that when we are talking about raising taxes, we are at the same time eliminating premiums, copays, deductibles, any out-of-pocket expenses. So it never bears out. And so we often say in the single payer movement, which do you want? Do you want to pay tens of thousands of dollars in taxes and use those taxes for your health care to keep us alive? Or do you want to pay tens of thousands of dollars in taxes and then pay more tens of thousands of dollars when you need that health care? It just, the math doesn't math, as the younger kids, I guess, say. So there is something new that maybe some of you have seen recently. Ed Markey reintroduced a bill from that was new in 2023. It's called the State-Based Universal Health Care Act. It was just reintroduced 2 weeks ago with a press conference with some of the folks you see here from different states, including Gustavo Rivera, our lead representative in the Senate on the New York Health Act. And what this act does at the federal level is it simplifies that waiver process that we talked about for states to do single payer on their own. It actually mandates some federal support if a state moves to a state administered system. It also mandates that 95% of the state residents covered within 5 years of implementation, and then the state must also demonstrate how they will cover the last remaining 5%. And as Gloria alluded to, there are lots of states. We can't go over each one of them, but we're just highlighting some of them that have single payer bills or initiatives to study or implement a universal healthcare system. Maine has a public health law that calls for a universal healthcare system, but they're going to need that state-based Universal Healthcare Act to pass so that it can actually be brought to fruition. There are folks who are just lobbying two different bills to study the feasibility of universal healthcare in Maine and also to create a blueprint. Now, yes, those measures did fail, but it's important for us to recognize that people are working on this and lobbying this right now. If I told you how many visits I went to in the past that maybe weren't successful right away with the New York Health Act, you would be discouraged. But we got there over time. And so it's not something that unfortunately is going to change overnight. Just to highlight a few other things, and then we're going to talk about advocacy and lobby and then open it up for you. We've got colleagues in Ohio and Michigan who have their own state-based single payer bills that they are in Michigan, it's called MyCare, and they've actually recently reintroduced that as well. Now, some have asked me what happened in Vermont, right? Didn't single payer fail after it passed in Vermont? And in summary, I want to say a few things. Number one, there were amazing healthcare advocates who did a lot of great work through through the years and got Vermont to pass single payer legislation in 2011. And actually, in 2011, the governor ran on that and was a strong proponent of single payer and very proud of it, and talked about his state being the first to successfully implement Green Mountain Care. But a few years after passage, something funky happened. Governor Shumlin started to back off. He started to say things like, I don't know how we're going to pay for this, which makes no sense because it had been studied many times before, and that was what we were advocating for years. And he talked about that it was going to be too much to institute an 11% payroll tax on business and 9% on individuals. Again, we're talking about taxes. We're not talking about replacing those with premiums, copays, deductibles. It's been well documented that Shumlin was politically on shaky ground and backed off single payer probably for that. But also, we know whether openly or behind closed doors, the healthcare industry lobby came at him very hard. No surprise. It's also been documented that the ultimate final structure of single payer that passed in Vermont was maybe not really single payer. So we shouldn't necessarily slam it as a failed effort. It actually included accountable care organizations, which are these insurance type conglomerates that you probably heard of that came with the Affordable Care Act. It seems like late in the final hour, he was influenced to add these into the single payer plan. And one of the experts that I follow from Minnesota talked about calling it a single payer system with ACOs is an oxymoron because it's now there will be different payers, just quite simply single payer versus three different payers in the state. And he was somewhat convinced by a report that thought we can put these ACOs in. So there are reasons it potentially didn't go through. But I'm not naive to expect that we're going to have a tax again if another state gets there. So we asked folks who had participated in a lobby visit. We're going to now shift on the last few minutes before we open it up for questions. Gloria and I wanted to share a few tips and strategies on advocacy, which is where Gloria is going to start, and I'm going to talk about lobbying for a few minutes. Gloria?
Yeah, thanks, Danny. Just quickly, because many of us have been doing this not only around healthcare justice, but about many other issues that our party champions. And so, when we're talking about advocacy, we're talking about a lot of different activities. Our focus is to influence public opinion and policy. Next slide. And so some of the things we're suggesting and that we've done, we want to hear what you've done. A couple of people have already put some things in there that they're working on, but is like find a local, or is there a local organization in your state that's focusing on healthcare coverage advocacy, right? Maybe there's not a single payer bill at the moment. Maybe nobody's really developed anything at that point, but are they talking about healthcare advocacy and making some changes? So we do have the New York Health campaign. CalCare has a very big organization with some of unions and other organizations in there. For instance, in both in California and here in New York, the nursing unions are really at the forefront of this. Next slide. Healthcare Now, if you just to check out their website, they will actually list quite a few states that have a local single payer group. Obviously, they're all going to be in different stages of development and robustness, but that's a great place to start, especially if you're thinking about your local Green Party chapter to say, how can we get connected to a group that's already doing that work? How do we bring our skills and our perspective to that organization? Next slide. So Physicians for a National Health Program, where Danny and I are members in the New York Metro chapter. They also have chapters in many other places. That may be another place to connect. Actually, before I was on the board, when I was working in healthcare initially and doing some other political work, I just started going to their forums and listening to their different speakers, learning more and more about the different aspects of not just single payer, but racism in healthcare and, profit in healthcare, so many different things, and connected with people there. Next slide. And then, of course, our National Green Party has that in our platform, of course. And then, our other state parties have it in their platforms. They're out doing work. This is just a sample of them. Some of you are already talking about it in the chat, and I've talked to people from Massachusetts and other places about what they're doing. And so, just what is the Green Party in your area doing, or how might they get involved? Next slide. And, green solidarities is interesting because one of the things that, I try and think about is there a group or organization working on something that's going to advance the possibility of Medicare for All, single payer healthcare? I spoke at the Medicare for All rally some years ago. That is different than looking at something like for incremental change. And that's really, I think, maybe an interesting discussion at some point in the party, if not today, which is how do we make that decision? Well, in New York, I saw somebody commenting about funding for people who are undocumented currently. There is, kind of a companion bill with the one we have in New York called, Care for All, just to help cover recent migrants. And so how do you decide, well, this group is not talking about single payer just yet, but they're really promoting something, some kind of community health program or something else, maybe participating with groups that are fighting hospital closures. There's a lot of ways to make connections without feeling like we're compromising how we feel as Greens, which is we need a national health insurance program. We need to work on state insurance programs, but we can actually fight going along on the picket line, because most of the time unions are in negotiating and fighting about their health care. Next slide. And Danny, you're going to take over for a lot of
Sure.
things.
Yeah. Thanks, Gloria. So last few minutes here, and then we're going to open it up. There's a lot of great comments in the chat. Keep putting them in there. We're going to address those just in a few minutes. I'm really excited about what people put in there. So again, Gloria and I have been part of Physicians for a National Health Program and the Campaign for New York Health Years. And most recently, the Green Party of New York was a co-sponsor with, you can see, a wide coalition of groups on our annual lobby day for the New York Health Act. So what is lobbying? It's basically a brief visit with an elected official. You're kind of lobbying for them to support a bill or piece of legislation. It can be a small effort where it's just a few folks getting together, meeting with their elected official, or it can be part of one of these annual large lobby days. Here I am in one of the meetings that we had recently. I will, in my 25 years of single payer advocacy, the first few years I spent being very intimidated and afraid to lobby. I felt that, I need to be an expert. I need to understand how we pay for the New York Health Act, how we pay for Medicare for All. I need to be able to answer every single possible question that can be thrown my way. Please listen to me and in saying that is not true, and you do not need to be an expert. In fact, I've often been reminded, we often talk about the First Amendment, our right to freedom of speech and press, but we don't often read the whole amendment. And that amendment ends with the end to petition the government for a redress of grievances. You have your First Amendment right to lobby these folks. They work for us, their staff work for us, they're paid by us. So this is your right. And when you get into a lobby meeting, it's more about what you're bringing rather than being an expert. And I'll talk a little bit more about that. So how to do it? Well, you can do an in-person meeting. During COVID, we had a lot of web-based meetings, and we still sometimes have those, so we can get folks across the state together. You can have a phone call, you can email, you can write, you can do social media. Studies have shown the more you contact your legislator in different methods, the more likely they are to listen. What is the objective? You should go in with one or two objectives, but don't shoot too high. Getting, going in there saying they must sign on to this single payer legislation before they leave is unrealistic. You're there to talk to them. You're there to share personal stories. You're there to educate them and discuss the policy. And also, guess what? You're there to do intel, right? You want to gather information about their concerns, criticisms, and why they might not be co-sponsors yet. And also, maybe what's most important is you're there to build relationships. I know many of you have had those relationships, and I know as Greens, it can be contentious because we're so often disappointed by our elected officials. But when you're lobbying, you want to understand that that's going to be a long-term um, relationship. Gloria and I have used this structure from our PNHP New York Metro chapter and from the campaign of New York Health. We usually go in with a team leader or facilitator. We go in with someone who's going to tell a story. We often go in with someone who's going to explain the bill so we can go on who has a little bit more expertise or knowledge. We usually have someone do an ask, and we have note takers, observers, and you can have more than one storyteller or more than one note taker. Um, it's so critical to craft a story. I shared with you one stories that are really gut wrenching for me to share. But what I notice time and time again is that when I go to lobby as somebody who has struggled with healthcare coverage with you or your family, this is how we affect change. It's pretty clear that when you tell a story, the listener connects to it in a different way. They make connections to how you experience what is happening, and hopefully they will make that connection, and hopefully you'll make that connection to why the legislation is so important. There's lots of ways to craft your med story. Our chapter has done Med Story Monday, and going to have Gloria share something with you towards the end. So how do we structure the lobby visit? Usually at least 3 or 4 of us go. We try to have a constituent, so meaning somebody who lives in that person's district, but it's not a mandate. And we usually recognize that it's going to be a short meeting. It's often 10 to 15 minutes. You're going to do a quick welcome and intro. Someone can start with a story. You can highlight key points of the bill. You can make your ask, and you can have an open discussion and QA. What are the asks? What do we mean by that? Well, if they're already a co-sponsor, there's still a lot you can ask of them. You can ask them to convince other colleagues to become co-sponsors of the legislation. You can ask them to urge speakers to finally bring legislation to a vote. You can have them co-author. Obviously, if they're not a co-sponsor, you're going to ask them to co-sponsor, but you're going to find out what they're uncomfortable with. Probably the most important thing is to follow up. They hear from tons of folks every day, and it's the ones who follow up and build that relationship usually are the ones you're going to be able to turn. Gloria alluded to this, but why organize with Greens? Okay, I think most of you here probably are here and know about how the corporate duopoly has co-opted healthcare struggles and fights. And really, oftentimes we say the Medicare for All has died within the duopoly. And a great example is what's happened right here in New York. We had a quote, Democratic supermajority Assembly, Senate, and governor that are Democratic. We had a majority of co-sponsors on our New York Health Act from 2021 to 2024, practically 4 years. And the Speaker of the Senate, Stuart Cousins, did not bring it to a vote or even a hearing, and Governor Hochul has not said one word about it. So we've done the work, and they have again failed us. In California, it's the same story. Many of you already put stuff like that in the chat. Champions of single payer back off when push comes to shove. California's had a supermajority in their assembly, senate, and governor for many years and many times through the last few years. Even Gavin Newsom was quoted many years ago in 2018 saying, "I'm tired of politicians saying they support single payer, but it is too soon, too expensive, or someone else's problem." Where's Gavin Newsom now? And that takes us into someone who you know, and maybe hopefully, if you haven't heard, Butch Ware, our VP candidate in the last presidential election, is running for governor. And he has already made CalCare and single payer in California a top priority and issue that he is unwavering in his support for. We often talk about how Greens can push Democrats left. Gloria and other predecessors in the Green Party have shown me that they were very instrumental in pushing Dems on the fracking ban in New York State, that they were critical in ensuring that the state moved to a $15 minimum wage. So we're ending up here. We want to take the last 15 minutes for Q&A. I'm going to share a few shameless plugs. There's a recent mockumentary, 20-minute long, on the New York Health Act that I was part of, and I will share the link for that. And also, if you go to Green Party videos on our Green Party National YouTube page, you can see a little bit more on the national Medicare for All movement that Gloria and I gave last year. So we often end with saying we want single payer because it's the only way to achieve universal comprehensive coverage that's equitable for all residents in the United States. You know, we're sick and tired of the system telling people they're not wealthy enough, they're not born in the right situation, they don't have the right skin color, they don't live in the right state without Medicaid expansion, and they're not worth treatment. We don't believe in that. We believe healthcare is a human right. It's a way to stamp out poverty. And I'm sick and tired as a healthcare professional of trying to even entertain what insurance plan or how someone has the ability to pay for their healthcare. This famous quote, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhuman because it often results in physical death." That was said by the late, great Dr. Martin Luther King Jr. For everything that he stood for everything that he saw before he was assassinated for speaking words. He saw how terrible our healthcare system was. And I would be embarrassed for him to see what it is today. Not much better. So I'm going to stop sharing and kind of open it up. I might Gloria, if you want to see like hands, there's so many great comments. I'm going to kind
Yeah,
of start at the top.
I see
Uh,
Adam
yeah,
has his
Adam,
hand
why
up,
don't you
so
start,
okay.
Adam? Yeah.
Can you hear me right now?
Yes, we
Yes.
can. Yeah.
Okay, I wanted to make sure. I am disabled from birth because I'm legally blind from birth, but later on in life, I had to use a power wheelchair. And a couple things that's been on my mind through this whole thing is one, if you're on Medicare and Medicaid, which I am on Medicare and Medicaid, Medicare will pay 80% of your hospital or doctor bill, and then Medicaid will, if Medicaid's your secondary, it'll pay the other was it 20%? But if you leave the state you live in, so like if I leave Utah to go on a trip or I'm in another city in another state for whatever reason, if I have to go to the hospital, Medicare will pay that 80% of that bill, but Medicaid will not. And that's a huge problem when people talk about that there's no way of having a nationwide healthcare system. And then the other thing that I've noticed using a wheelchair, one day I was at the wheelchair shop and I was talking with the technician and I asked him the question of if I were to come in here with cash in a briefcase and I wanted to purchase the same chair I got through Medicare and Medicaid, how much would that have cost? And he said, well, your chair was $80,000, but if you came in and just paid cash for the chair, it'd have been about $60,000. So unfortunately, our healthcare system is being treated just like some regular business decision instead of, where people are trying to make money off of the backs of other people, which the
Absolutely.
costs,
Absolutely.
the cost for healthcare should be already, if a fair wage for a doctor is a certain dollar amount, that should already be added into the national budget, or like when money's printed, it shouldn't be something that people are like paying. It should be totally different. And then healthcare as well. Like, I know that some people that don't realize it, but there's Western medicine, which we've been talking a lot about Western medicine. But if you want to see a naturopathic doctor, medical insurance, especially like Medicare and Medicaid, will not cover naturopathic medicine. But unfortunately, from what I understand, is doctors, when they go through training, a naturopathic doctor has to go through all the same training that a regular, like typical doctor that we know of, goes through. And then they have to go through additional training to be a naturopathic doctor. But yet,
Yeah, this is
doctors,
absolutely true, Adam. And, I think first, thank you for sharing your story. I think this is what's powerful. I think if you're lobbying, this is the kind of thing that I would share because this is what moves politicians. You don't need to bring the numbers to them. We can always follow up in lobby after lobby visits with numbers and details and wonky policy stuff. I would say Adam brings up a concern about the state single payer movement. What if I travel? What if folks are coming? The reality is, in the New York Health Act, if you're traveling to here, there would be coverage, and if you travel outside of this, but you're a resident, there are some stipulations that we may keep that coverage for you. But our goal, Adam, is 100% to get one or two states on this single payer path, and then pass it across the nation. That is the ultimate goal. We don't want to have a fragmented system in that way. So thank you for those comments.
Yeah.
I'm looking at a couple others.
And
Yeah,
any other
Gloria.
comments well, one thing people have asked Danny is about a copy of the program. So I don't know if you want to put your email to send people a
Sure.
PDF
Yep.
of the slides, since some of them are PNHP, property or other things like that, but
Yeah.
you want to do that.
Yeah.
But does anybody else have a
That's
question?
great. Yeah.
Yeah, looking at the, I mean, there's some people still talking a little bit about how, yes, and I think Danny alluded to this, being I'm going to co-sponsor, and they get their name there. They don't promote it. Maybe they don't even vote for it, and they don't anything. So that is the first step. Once somebody's a co-sponsor, they don't get any prize from those of us who are lobbying them. They have to say, well, what are you doing next? How about a town hall? We'll come there. We'll bring our doctors. We'll bring our stories. You just organize it with your staff and get get the name out there for it. And the other thing I want to say is, like, yes, it can be frustrating, but another thing I think doing this kind of work, whether it's tabling, you may not have any initiative in your state right now, but if you kind of come out as the Green Party or joining with others, it's a way to really talk to the public. It's a way to have people interested. Like, what is the Green Party? Why are we fighting for this? And why do we feel it's more effective the more we get money out of politics, the more we have electoral opportunities and more electoral candidates than just the Democrats and Republicans. So it can also be a kind of internal organizing tool for your local to get people interested, and maybe to refresh those of us who have local chapters that sometimes are, getting a little less robust over time. Other questions? People could put their hand up, or trying to find, some people are just making great comments about what's happening in their state. Let's see.
Yeah, we're going to make sure the program, and I have links and materials that I want to give you as examples,
Right.
that will be sent out and shared with all registrants. So even folks who told me I can't make it to this session, I'm committed to something else. Yeah, so I will make
Oh,
sure.
I think Keenan has this, Keenan has their hand up.
Yeah. Yep. Keenan, if you can unmute. Yeah.
Oh, yeah. Yeah, I also wrote it in there. I'll just read it from there. In North Carolina, we have several members who are healthcare professionals but have not become active on single payer in the party. How did the host, I missed the beginning, so I don't remember your name, as a healthcare professional, how did you become active as a green for single payer?
Oh, thanks. That's a great question. I maybe alluded to it.
Very beginning, yeah.
Yeah. Honestly, Keenan, I started medical school in bright-eyed and bushy-tailed, although it took me a few years to get into med school, and I worked in Boston and cared for folks experiencing homelessness before med school. And I worked with an amazing doctor who went out on volunteer every week, and we cared for folks in the streets of Boston. And I started noticing that, hey, we want so and so to come to a clinic. We want to give them a prescription for a blood pressure medication. We want to do this, that. And they kept, I didn't understand, why are there so many hoops to jump through? Why is penicillin, which I heard, even before medical school, is like the oldest antibiotic known to man? Why? Physician said to me, you need to go learn about single payer. And when I got to medical school, I noticed there was no education in the medical school curriculum about Medicare, about Medicaid, about private health insurance. And I ended up at PNHP meetings just like Gloria. And but the green shift for me was really 2012. And 2010 to 2012, getting involved with Occupy Wall Street and really feeling like when Obama won, that there was actually going to at least be a discussion of single payer, and then to see what a farce the Affordable Care Act is and how those quote subsidies were really just taxpayer funding of the private health insurance system, and how we all knew that medical debt was not going to be abolished, that premiums were going to go up, that the cost was going up. And so I found Greens and others in New York City who kind of mentored me and took me in, and I have not turned back since. And it is still a struggle, as we mentioned. But we also still, as Greens, can hold elected officials' feet to the fire. As I mentioned, Greens have pushed left on Democrats, on fracking, on fight for 15 minimum wage. So it's still our job, I see it, to advocate strongly for single payer. So thanks for asking that. I saw another, thank you, Barbara, for the thumbs up. I saw another hand. Alan, did you have your hand up? Oh, so um, Gloria, was there other I'm looking, I have cut and pasted the chat, so I'm looking through that. Uh, Gloria, anything you wanted to bring up that
No,
I haven't? Yeah.
just sort of a lot, I think a lot of comments of kind of like how even co-sponsors or Democrats, as we know, are going to, uh, don't really step up, even if they do co-sponsor. There's a lot of conversation about that. And, I think the sentiment from people, which is, this is a moment for the Green Party, both not just, not, certainly because the recent bill that has been passed is going to slash healthcare, Medicaid, Medicare. What was interesting earlier, people were saying, I think you should say single payer because people don't like Medicare. The nomenclature has changed a lot over the years, depending on how public reacts. I think people don't like Medicaid because they think it's the handout to the poor. If you interview seniors, and some of us are on this call, when they did that over the years, seniors would say things like, I don't want the government touching my Medicare, not understanding that Medicare is actually a longtime government funding program with a very, very low percentage of any administrative costs. It's not really looked at it that way by people. They don't understand that. So that's how we've kind of moved into making sure we say improved and expanded Medicare for All, because those of us, someone referred to the donut hole, to Medicaid managed care, that there's a lot of things left out of what Medicare covers right now, especially as people reach their more senior years. You're going to need those things like dental, vision, things like that.
Gloria, I wanted to add, it's my fault. We had a slide highlighting Andrew Stackhouse in the state of Washington. I think someone might be on there. I've recently learned about Andrew, and he's someone who is not only in the Green State Committee in Washington, but leads a state single payer organization and also is running for governor. I know there are many Greens here. I know we're tired of hearing where are Greens every 4 years. We know Greens are doing things, right? So I'm not worried about that. But to me, I also add to what Gloria is saying, like if New York wants to stand up to Trump and protect and defend immigrants, one of the simplest ways to do that tomorrow is pass the New York Health Act. So anything Governor Hochul and these politicians are telling me, it's empty promises. And one of the reasons we want the Senate to bring it to a vote is we also want to weed out who a co-sponsor who will then back off when it actually comes to a vote. We need to know that. Not only the public needs to know that, but we need to know that with our strategizing efforts. And, you know, Gloria and I are trying to brainstorm with other Greens in New York. How do we create a bit of a pressure campaign coming from Greens to push even left further? You know, single payer, Medicare for all, let's be honest, it's not one of the radical legislations and efforts that the Green Party and other politics that we believe in our core values. It's quite frankly an embarrassment time and time again, every time I speak about this as a physician, as someone part of the healthcare force, that we don't do this. This is not radical. This is not pie in the sky. This is bread and butter, social, you know, societal values, and really single payer, you could even say, is the floor. Others have talked about, even the Green Party platform talks about a nationalized health service. Again, we get smear attacks of socialized medicine. Guess what, everybody? I'd like for you to know that I have worked in a socialized medicine system, and it's right here in this country. It's called the Veterans Health Administration Service. So yes, the VA system that cares for folks who've completed military service, that's socialized medicine. All it means is that the government owns the hospital space. They are the employer. They pay for the services, right?
So
There's nothing.
yeah, it's
There's nothing scary
4:30,
about
and
that.
we know that some people have to move on
Yes, thank
to
you.
to another session, and another session may be coming into this room. So we want to thank everyone. We know it was a lot of material. We really appreciate your comments. Love your stories. Use those when you're lobbying and when you're meeting people. Danny, thank you for partnering with me as
Thank
always.
you, Gloria. Thanks, everybody. Yeah,
And we will say goodbye to everyone and stop the recording.
I'll stop the recording. Yeah.